So this is a talk on autism and functional neurological disorder, and I'm re-recording this to include the pictures. So during this talk, I'm going to be using identity first language, though I'm aware that there are parts of the autistic community who prefer person first language. I'm going to go with identity first for simplicity. And I want to make it clear that I'm not here to present any unifying theory of a relationship between FND and autism, because I know that FND itself is very multifactorial and autism is highly heterogeneous as well. But I would just like to raise some ideas and present the evidence that I've seen so far. And so this will be a structure. I'll spend about the first 15 minutes talking about FND and autism, and then I'll start giving some clinical hints at an association, give an overview of the evidence, and explore mechanisms that might be relevant. And I'll also discuss implications for clinical care as well. So FND is a disorder where the primary pathophysiological processes are alterations in the functioning of brain networks rather than abnormalities of brain structures. And the networks that might be abnormal include ones related to voluntary movement, and these might be abnormally influenced or hijacked by networks serving affective and threat processing. These abnormalities give rise to symptoms related to motor, sensory, or cognitive disturbances, which are often persistent. And importantly, it's not a diagnosis of exclusion, and it's important to assess for semiological features and positive signs, such as Hoover's signs, as well as further signs of inconsistency, which might be related to attention and distraction. And these signs of inconsistency are not an indicator of feigning, but rather they're inherent to the pathology that underlies functional neurological disorder. And stigma is common, with 85% of patients reporting feeling being disbelieved or disrespected when visiting a medical practitioner. And this quote from the FND Hope website I find helpful. It's the FND is the brain's inability to send and receive signals properly rather than a disease. And these are some of the terminologies that have been used and are still used to this day to describe functional neurological disorder. And the change in terminology towards FND has been influenced by a change in our understanding, with a focus on function rather than structure, and acknowledgement of patient groups' preference as well. And there are various frameworks for understanding the multifactorial nature of FND, and each one uses different levels of integration and granularity. But a very common one is the use of the predisposing, precipitating, and perpetuating framework, which would include factors like predisposing factors, including childhood adversity, precipitating factors such as medication side effects, or perpetuating factors such as heightened bodily attention, as well as misdiagnosis. And a nice example is where the triple P framework, as well as the biopsychosocial framework, which is often integrated alongside it. A nice example of that is with the data presented here by Diaz et al., where they described the magnitude of previously experienced childhood physical abuse in patients with motor FND correlated with resting state connectivity strength between salience limbic network brain areas and the precentral gyrus. But it's important to remember that childhood adversity isn't always present in FND, and around half of patients do not report it. And this is important because historically there's been too much of a focus on trauma, such that FND patients weren't necessarily believed when they said that they hadn't experienced traumatic childhoods. But we've moved away from this historical psychodynamic trauma-focused model to a more recent greater emphasis on how dysfunction of higher order cognitive processes related to agency, emotion processing, and attention constructs give rise to functional symptoms. And this is a nice way of displaying all the constructs which are relevant. And then this example as well from Drain et al.'s publication shows how symptoms are related to, such as functional movement problems, are related to constructs such as agency, emotion processing, and attention, which are related to neural circuits, such as salience and limbic circuits, and temporal parietal junction-based circuit, especially for agency. And this is a quote from Andy Clark's book, The Experience Machine, where he describes the contours of functional problems often follow our intuitive notions of disease or anatomy rather than medically or physiologically sound ones. And these examples of this would be leg dropping, tubular visual defect, and non-epileptic seizures where people display episotonus and head turning from side to side. The shape of the impairment follows the shape of the person's own predictions and expectations as well. And a helpful model for understanding functional neurological disorder comes from computational psychiatry, which puts emphasis on how the brain processes information and perceives the internal and external world. And related to this is the predictive coding framework, which helps bridge the gap between the neurobiology and subjective experience of the person. And it demystifies this unhelpful separation of organic versus non-organic. Predictive processing provides a theoretical framework of symptom onset and perpetuation through attentional and belief-driven processes. And the reason I want to just go through this is because predictive processing is atypical in both functional neurological disorder and autism, though not really in a uniform way. And so just to outline this predictive processing model of the brain, it starts with the brain being a generative model. It generates predictions of impending perceptual events and compares the predictions to sensory data, which is inherently variable and noisy. These predictions that are made are influenced by both past experiences as well as context. And when there's a mismatch between predictive and sensory data, this forms a prediction error, which revises the prediction to match sensory data and create perception and drive action. A crucial part of the process is precision weighting, which is related to attention. And it's the brain's way of balancing the influence of sensory evidence against predictions. It's a way of using a sort of neuronal volume control to tell itself where and by how much to place its bets when it comes to formulating experience. And when this process goes wrong, our brains will bet badly. They will misestimate what to take seriously and what not to take seriously, thereby generating false or misleading predictions. An FND is characterized by the development of erroneous perceptual inference. Predictions of pain or impairment, for example, become highly overweighted, and those predictions overwhelm the actual sensory evidence, forcing experience to conform to our own misplaced expectations. And the inaccurate predictions are then made worse by attention, which ups the precision and drives symptom production in line with abnormal predictions, as a sort of self-fulfilling prophecy, which is apparent when attention is distracted, with the main example being with functional tremor. So attending to the tremor ups the precision weighting on the hidden expectation of the tremor, and this brings the tremor about. I thought this was another great quote from this book, where Andy Clark writes, "Since all human experience is constructed from mixtures of expectations, attention, and sensory stimulation, it will never be possible to experience either the world or your own body as it really is. There exists a deep continuity between cases where expectation and attention create symptoms from whole cloth, such as in FND, and cases where they also reflect the operation of some more standard form of disease or injury. Functional disorders simply lie at one end of the spectrum." And moving on to autism now. So this is a heritable lifelong neurodevelopmental condition, and its heritability in most cases is related to a combination of hundreds of variations or gene variants. And there is a recognized but still ongoing sex bias in diagnosis, where it has moved down over the years from 10 to 1 in terms of female to male, 5 to 1, and also now currently 3 to 4 to 1. And often women are undiagnosed or misdiagnosed or diagnosed later, and a late diagnosis is associated with worse mental health outcomes. And as you move along the IQ continuum, this kind of rate of female underrepresentation in autism diagnosis worsens, such that if a woman has a co-occurring intellectual disability, they are more likely to be diagnosed with autism rather than if they have a higher IQ. And autism is typified by a divergence in cognitive style from that of the non-autistic population, and the core features of autism manifest very differently between individuals. And so there's differences in communication and interaction, and this might manifest as delayed language development or atypical use of verbal or non-verbal language. Difficulty with interactions can involve difficulty maintaining and forming social bonds, not without a desire to do so, however. And interestingly, from the work by Professor Fletcher Watson, we know that some of these difficulties in communication and interaction are actually diluted when autistic people communicate when interact with other autistic people. And then there are also the non-social symptoms, and this involves repetitive and stereotype behaviours such as hand flapping or rocking, and also an intense desire for sameness, focused interests, and after the DSM-5, sensory processing differences involving hypo or hyper reactivity. And it's important to remember that just because someone has maybe severe difficulties with communication interaction, they aren't necessarily going to have the same level of severity when it comes to repetitive and stereotyped behaviours. So there can be stark differences between those two constructs within the same autistic person. And it's important to remember that symptoms can often be masked, and sometimes they will only be unmasked when social stresses are high enough. So it's important also to remember the strengths of the autistic community, especially related to the attention to detail, pattern recognition, which might manifest as an actually increased ability to learn a language, especially East Asian languages. Then there's also talents for art, music, maths, and memory. And it's also been described that there's a strong sense of justice commonly found in the autistic community, or an unwavering integrity as well. And some of the challenges faced by autistic people include employment disparities, a higher risk of child maltreatment and bullying, which often continues into adulthood, and a higher rate of trauma as well within the autistic community. And these can be related to differences in interpersonal communication, which can make it harder to engage in things like job interviews, also to form protective relationships and to recognise early warning signs in people. And sexual violence is an important factor when considering why an autistic person might be more prone to mental health conditions, but also functional neurological disorder, especially as sexual violence often involves betrayal, and traumas that are high in betrayal lead to severe PTSD and also dissociation. And cisgendered women and gender minorities are most at risk within the autistic community. And Prof. Hafe's work has shown us that the autistic community can be more prone to post-traumatic stress disorder, and also the events which are found to be traumatic are not necessarily the same events which might be traumatic for neurotypical adults, and this shouldn't undermine or negate a diagnosis of PTSD. And these questions and these points should really raise the idea of are these autistic challenges or are these societal challenges? And we should remind ourselves of the medical versus the social model of disability when thinking about this. Medical morbidity is common, and especially relevant to FND is a higher prevalence of epilepsy as well as migraine and headaches in the autistic community. And there was a really good poster by the team at St George's presented at the BMPA a couple of years ago on migraine being a predisposing and precipitating factor for FND. Psychiatric morbidity is common, with approximately 70 to 80% of autistic individuals across all age groups experiencing mental health problems, with anxiety and depression being the most common. And this is, and we know that anxiety might have a typical presentation when compared to neurotypical manifestations of anxiety. And in the autistic community, it might be related to loud sounds or even inanimate objects. There might be an intolerance of uncertainty and a worry about change. And there can also be associated dissociative symptoms at a higher rate in autistic people with anxiety. Suicidality is more common, with 6% in this sample experiencing suicidal ideation, which is 9 times higher than the general population. But this study was done in individuals diagnosed with late autism. That's is relevant to women of autism especially. And this is a paper from Prof. Hafe's team where they discussed 3 closely related ideas important for understanding anxiety in autism. The first being atypical sensory function, and it's known that severity of anxiety appears to be higher in individuals with more severe sensory dysfunction. difficulty identifying labeling emotions or alexithymia, which I'll come back to speak about, and also intolerance of uncertainty. And intolerance of uncertainty has been found to mediate sensory sensitivities and anxiety, which makes sense because if you have atypical sensory functioning, then this might exacerbate uncertainty for both external and internal interoceptive stimuli. Let's do out time for this. So why look at autism and FND? So autism encapsulates differences in emotional processing, sensory sensitivities, and cognitive profiles which are relevant to the way that we think about FND. For example, there's atypicalities in overlapping constructs such as attention, alexithymia, interoception, and sensory overresponsivity. There's overlapping network atypicalities and limbic salience and interoceptive networks, which are not mutually exclusive from each other, but commonly involve the amygdala and insula as well as the anterior cingulate cortex. And there's alterations in predictive processing profiles and a shared higher co-prevalence of neuropsychiatric and medical conditions, such as functional somatic syndromes, hypermobility, epilepsy, and anxiety and depression. So just starting with joint hypermobility spectrum disorders and hypermobile EDS. And this first study was a Swedish nationwide population-based study where they looked at psychiatric comorbidity and hypermobility spectrum disorder, and they found that in individuals with EDS, there was a 7-fold higher chance of being autistic. In Delgado's et al.'s 2022 study, that in a sample of patients with motor FND, 21% of patients had clinical features suggestive of joint hypermobility, especially those with fixed limb dystonia. And individuals with hypermobility are up to 7 times overrepresented among those with panic or anxiety disorder. And Jessica Eccles' team has produced really fascinating research about the association between hypermobility and greater bilateral amygdala volume and anterior cingulate cortex structural differences. And so this might highlight why a subgroup of the autistic community might be at higher risk of developing FND, or one of the factors contributing to it. And there is also an interesting link between autism and, or higher co-prevalence of autism and central sensitivity syndromes, which are also found at higher co-prevalence in FND as well. And this includes chronic fatigue syndrome, fibromyalgia, and irritable bowel syndrome. And Grant et al. Did a really interesting study involving 973 autistic adults from the Netherlands Autism Register. And what they reported was that a fifth of participants reported one or more central sensitivity syndrome diagnosis. And is thought to have overlapping clinical and etiological characteristics between central sensitivity syndromes and FND, especially augmented sensory signaling of the central nervous system, and this giving rise to core features of fatigue and chronic pain. So a higher prevalence of central sensitivity syndromes within the autistic community might also suggest that a higher prevalence of functional neurological disorder as well. And this table just highlights the higher prevalence of personality disorder within functional neurological disorder. And the reason I've included this is it might hint at a high rate of autism misdiagnosis within FND. So this study looked at the rates of conversion disorder or somatoform disorder within BPD population, BPD sample studies, and they found high prevalences of both. And so we can think of this as being, just as there may be a sex or gender bias related to against the diagnosis of autism in women, there may be a sex-gender related bias towards diagnosing BPD in women, which likely compounds the extra barriers to healthcare as well, and results in more diagnostic overshadowing. And so evidence exists that autistic women are more likely to receive a diagnosis of BPD relative to non-autistic women, and diagnostic bias is an issue. Certain behaviours are more pathologized when exhibited by women than by men. Now I just want to go through some of the evidence that I gathered from a literature search back in March of 2022, where 934 studies were screened down to 11. And the first one is from population studies. Nimmo Smith et al. Used a Stockholm youth cohort to look at anxiety-related disorder in autistic adults and found a relative risk of 3.42 for somatoform disorder and 6.45 for dissociative disorder. In a Danish national registry study, they looked at adults who were diagnosed with autism in adulthood and compared with those who weren't. And what they did is they looked back at the childhood diagnoses received by those two groups. And so for adults diagnosed with autism in adulthood, their childhood diagnoses, there was an odds ratio of 5.68 for dissociative and conversion disorders, which is FND, compared to those who weren't diagnosed with autism in adulthood. And there was an odds ratio of 2.99 for somatoform disorder. Then this study was a retrospective analysis by the team at Great Ormond Street, by McWilliams et al. And the psychological medicine team there had noticed a higher prevalence of autism or autistic traits in young people referred for non-epileptic seizures. And when they looked at it, they found that 16.9% had a diagnosis of autism, and the autistic young people with non-epileptic seizures had significantly higher rates of OCD, PTSD, ADHD, and tic disorders as well. And then this is a study by Mystico et al., where they looked at autistic traits in a sample of FND patients, and they looked at functional symptoms in a sample of autistic participants. And they didn't actually find any significant difference between in the autistic number of autistic traits in the FND sample versus the normal sample. But what they did find was a higher, and this is in the bottom row, they found a higher prevalence of functional neurological symptoms, significantly higher, in the autistic group compared to the non-autistic group. And when they looked at the responses of participants to the sensory perception quotient, they found that hypersensitivity to touch was associated with significantly more frequent functional neurological symptoms in the autistic group, namely functional weakness and paresthesia. And this was a study that we published in early of last year, where we looked at 91 consecutive referrals to an FND outpatient service at Queen Square, and we reviewed data that had been gathered on autistic traits using the autism quotient, alexithymia, generalized anxiety, social phobia, and symptoms of ADHD and dyslexia, and somatic symptom severity. And we found that of those 91 FND patients, 40% scored 6 or above on the AQ10, 40%, and scoring 6 and above on the AQ10 qualifies for a diagnostic assessment for autism as per the NICE guidelines, but you'd have to take this within the clinical context, of course. And 40% were alexithymic. And the AQ10 positive group scored significantly higher on self-report measures of alexithymia, depression, generalized anxiety, social phobia, and symptoms of ADHD and dyslexia. And there was a strong association between AQ10 score, meaning the number of autistic traits, and somatic symptom and severity score, as measured by the PHQ-9, suggesting that autistic traits are associated with a higher severity of somatic symptoms. Then this study was a cross-sectional observational study where they recruited through the FND Hope charity and administered an online survey to subjects who reported a diagnosis of FND received from a medical professional. And what they found was that of the 344 respondents, 7.8% reported a diagnosis of autism, which is significant given that the sample was 90% female. And a quarter reported having a first-degree relative with autism spectrum condition. They also asked respondents to complete the adult autism subthreshold spectrum questionnaire, which is really helpful because it incorporates both male and female presentations of autism in terms of typical presentations, as well as criteria introduced by the DSM-5 related to sensory hypo or hypersensitivity. And they found that 70% of the respondents scored in the range suggesting clinically significant autism spectrum condition. But obviously you have to bear in mind there will be a large response bias within this study. So just to just go through some of the possible mechanisms, obviously the psychosocial factors are very important in FND, but I've covered most of those. And I just want to look at more at internal mechanisms now. And so alexithymia is one to consider. It's a dimensional personality trait entailing differences in recognizing emotions from internal bodily sensations. It's not inherent to autism, but it's found around half of autistic adults compared to 5 to 10% of the general population. And it's a well-researched driver of anxiety. And it's associated with this reduced ability to distinguish affect-related arousal from other bodily sensations. And its relevance to FND, I feel like, is outlined in this seminal paper by Jungerligens et al. On the theory of constructed emotion and how this applies to functional neurological disorder. And it lies in the fact that alexithymic patients are more likely to experience physiological markers of panic and anxiety without reporting an emotional state of anxiety, the so-called panic attack without panic phenomenon. And the theory being that alexithymic FND patients might fail to interpret autonomic arousal as anxiety during a precipitating event and interpret these sensations instead as symptoms of physical illness. So alexithymia could act as a risk factor for FND in that way. And another potential factor which might lead to an increased rate of FND diagnosis and autism is interoception. And interoception refers to the sensory signalling, the perceptual processing, and the psychological representation of sensations from internal bodily organs. And much of the research has focused on this mismatch between interoceptive accuracy, as measured by the heartbeat detection task, and interoceptive sensibility, which is your self-rated confidence. And it's also thought that interoceptive abnormalities may be central to the etiology of alexithymia as well. And there's significant evidence of altered interoception in FND, but also the interoceptive profiles of autistic adults and children have been found to be similar to patients with FND, with functional seizures in particular. And at the BNPA a couple of years ago, Professor Garfinkel presented her research where they demonstrated that autistic individuals have reduced interoceptive accuracy as measured by the heartbeat detection test, and exaggerated interoceptive sensibility, reflecting an impaired ability to objectively detect bodily signals alongside an overinflated subjective perception of bodily sensations. And this was predictive of anxiety. And this has been further corroborated by a meta-analysis by Williams et al., which did report that a reduced interoceptive sensitivity as measured by the heartbeat detection task in autism. Although there are mixed findings when different methods are used or different dimensions of interoception are explored. And just like our perception of the external world relies on predictive processing, interoception also relies on comparing a predictive model with incoming sensory inputs arising from the body. And the deficit in interoceptive accuracy observed in autistic patients with FND might involve a down-weighting of bottom-up interoceptive signaling with a reliance on top-down predictions. And if these top-down predictions are abnormal and inaccurate and they cannot be updated or adjusted by bottom-up information, then this might lead to a vicious cycle where the entire system is compromised. And I thought this interview with an Japanese autistic PhD student was really helpful in describing the interoceptive difficulties that many autistic people face. He writes, she feels in exquisite detail all the sensations that typical people readily identify as hunger, but she can't piece them together. It's very hard for me to conclude I'm hungry, she says. I feel irritated, or I feel sad, or I feel something is wrong. The information is separated, not connected. It takes her so long to realize she is hungry that she often feels faint and gets something to eat only after someone has suggested it to her. And this really hints at impaired interoception, as well as this quote of inaccurate and sensitive interoception contributing to noisy affective signals in the body. And the difficulty in correctly perceiving interoceptive signals might be linked to the phenomenon of sensory overresponsivity, which is present in about 70% of young people who are autistic. They meet the criteria for sensory overresponsivity, and this is associated with emotional dysregulation and anxiety. Also, though, in FND, patients commonly report sensory experiences such as bright lights, loud noises and pain, triggering or amplifying their functional symptoms. And also in experimental studies, low neurological sensory thresholds are commonly reported in FND. And this quote, I thought, really helps describe the impact of sensory overresponsivity. From Donna Williams, the sensory overload caused by bright lights, fluorescent lights, colours and patterns makes the body react as if being attacked or bombarded, resulting in such physical symptoms as headaches, anxiety, panic attacks or aggression. And I just want to bring this back to predictive processing Which, as a reminder, is the brain's way to improve perceptual reliability by integrating top-down expectations or priors with bottom-up sensory signals, which are inherently noisy and variable. And Pellicano and Burr proposed that autistic individuals might use priors to a lesser degree, the hypopriors hypothesis, resulting in superior local processing and altered sensory responsiveness. And that superior local processing correlates with the weakened central coherence hypothesis from Prof. Happe and Prof. Frith. And the hypopriors hypothesis links in with this observation of enhanced sensory details in the autistic community, especially from studies using illusions, as the idea is that priors should impede performance on illusions. And there's a really interesting study in the bottom left by Becchio et al., where they found that with these vases, which have these cast shadows, that for autistic participants, autistic children in this case, the cast shadows hindered the recognition, suggesting that autistic children make less use of prior information to interpret the shadows appropriately. And so Pellicano and Burr described how without a template against which to match observed sensory evidence, the individual is less able to anticipate the forthcoming sensory environment in order to resolve the perceptual ambiguity. Sensory symptoms in autism would therefore not be due to fundamental differences in sensory processing per se, but rather reflect atypicalities in the way that incoming information is interpreted by sensory symptoms. Then Brock raised this alternative possibility that the autistic cognition could instead involve stronger bottom-up influences. And this was then further looked into by Van der Cruz et al. In 2017, where they displayed Mooney images to autistic and neurotypical participants. And what they found was that when they then displayed the meaningful kind of whole image, which would, in theory, kind of update the priors about the image, and then showed the ambiguous Mooney image again, that from exposure to the meaningful whole, autistic participants were just as good at updating their priors and using those priors to then perceive the ambiguous image again. And what this suggests, as per the authors, is that an overall reduction in all priors in autism does not seem likely. And so in summary, there's been a mix of findings, but there's sensory dominance, just different mechanisms which might lead to it, so high sensory precision or low prior precision or high inflexible prediction errors. And this quote from Stark et al. 2021 I feel is quite helpful, where they say there is perhaps a taxonomy of predictive abilities and not all of these are reduced. And so these are some of the questions that I thought would be interesting to ask about the meaningfulness impact of FND and autism if there is a higher prevalence. Would an increased susceptibility to FND and autism weaken the prior hypothesis? Could the change in high-level priors about bodily function and sensation in FND gain additional weighting as an adaptive response to noisy, overweighted sensory data seen in autism? Or could it be a consequence of a persistent failure of the model to generate error-free predictions, despite repeated updates, leading to a tendency to ignore new evidence within that domain? And even though this quote from this paper on the science of emotion and the theory of constructed emotion in functional neurological disorder, even though this quote isn't targeted or directed or meant to be about autistic people with FND, I thought it could actually be applied quite nicely in this scenario. And so the team who wrote the paper describe how the deficits in sensory processing, interoceptive accuracy, biased attention, among others, constructs, limit the use of precision signals and predictive errors to improve future predictions. We speculate that developmentally mediated disruptions in emotion construction play a role in the increased propensity for functional neurological symptoms in these populations. And I just want to describe some implications for care. FND care tends to be within an MD team framework of medical doctors or psychiatrists, as well as occupational therapists, CBT therapists, and also physiotherapists. And so we need to think about considerations for the assessment, environment, and therapeutic strategy to make them more neurodiversity affirmative. The assessment could involve screening, for example, with the adult autism subthreshold questionnaire and a thorough neurodevelopmental history. Obviously, you'd need to gain consent as well in this scenario. And also important not to assume differences in preferences if someone is autistic. One of my PhD projects involves a study on autistic survivors of TBI, and one of the survivors said how when she was in hospital, the nurses essentially threw a weighted blanket onto her thinking that she would like it, but with her tactile hypersensitivity, she really did not appreciate that. And also, we need to think about the environment. Sensory overload reinforces feelings of anxiety, exacerbating communication difficulties when accessing healthcare, as described by Sacker et al. And communication adaptations. And there's a really helpful publication called The Barriers to Healthcare Checklist by Raymaker et al. And they describe how processing speed impacts healthcare discussions, difficulty to follow spoken instructions as well. And also we could think about therapy provided for FND patients, and would there need to be adaptations to CBT, OT and PT in consideration of different learning styles? Could sensory modulation training to patients with FND be a helpful adjunct in treatment? And also considering the aligning dimension and sort of interoceptive experience that Prof. Garfinkel and her team outlined as well. And could this be applied not just to anxiety, but also to FND? And also there would need to be adaptations to CBT for FND as well, as many autistic people do not respond to typical psychotherapeutic interventions, suggesting autism-specific models and interventions are needed. And this might incorporate factors such as targeting intolerance of uncertainty, as well as interventions directed at improving sensory integration, which could help reduce anxiety in autistic people with FND. Also relevant to physiotherapy is a quote from one of my participants, again, an autistic survivor of TBI, who was undergoing physiotherapy in neurorehab. And she described to me the impact of one of the physiotherapists touching her and putting their hand on her shoulder. It just kind of feels intense. Like, it's not painful, but it feels like a big demand. And also, if somebody's touching me, that takes a lot of my attention and focus. So then if somebody's hand is on your shoulders, then I am so in that bit. So it's then really hard for me to focus on what you're saying or trying to understand what you're meaning, because so much processing or understanding or figuring out is just so much like, there is a hand on me, why is there a hand on me, get the hand off. It's kind of like, if one bit of the world is shouting at you, you don't have much freed up to deal with the rest of it, which really kind of underlies how powerful those sensory experiences can be. And this is a really helpful paper from Practical Neurology on the neurological consultation with an autistic participant or patient, And I thought the bottom one about the environment was really helpful, and also the clinic letter, where a standard appointment letter could be adapted to include bullet points explaining what will happen and include photos of the clinic or an autism-friendly leaflet about the service. And that would really help reduce that kind of, or it would help consider the intolerance of uncertainty about going to a new environment and a clinic. And then this is a really helpful checklist published in the Nursing Times, and it's also endorsed by the National Autism Society as well as NICE. And it's a checklist on how to make a clinical environment more autism friendly. And services could also start by looking at this tool called the Autism Healthcare Accommodations Tool, which is an online tool used in primary care that creates customized accommodations report for individuals to give to their healthcare providers. And so the autistic person goes to autismandhealth.org, completes a survey, and from that survey they then create a bunch of accommodations which can be used for the healthcare practitioner. And so you can just see how it goes into details on aspects of receptive speech, expressive speech, writing, use of telephone, as well as other ways of communication, such as give her time to process what has been said and check to make sure she is ready to move on. Also, give her blunt and concrete examples of what would happen if she does not follow the recommendations. And this is another quote from an autistic participant just about hospital environments. Hospitals are always weird temperatures. They're always bright. There's a lot of noises and are always out of sync. They're fairly unpredictable environments, like just quite a lot. I logically can get that hospitals are busy, but then equally it doesn't change the fact that you said this was happening at this time and it hasn't. And so now I've been wound up about what's going on. Like, well, you said that's going to happen. Is that going to happen, or is it not the plan, or have you changed the plan? And it kind of really highlights, especially to healthcare practitioners who really have normalized changes in plans in hospitals and what the environment is like, and we're so adapted to it, but how that might influence a autistic person who finds that environment novel and full of intolerance of uncertainty. And this is a summary slide. So evidence points towards a high prevalence of autism in FND. Relevant mechanistic factors include alexithymia, interoception, and sensory over-responsivity. And the FND MDT program could think of ways to screen for autism and also adapt the therapeutic strategy. So thanks for listening, and I think the questions section will be up next.